Hey NCS podcast listeners, this is your host Fawaz Al-Mufti from Westchester Medical Center, New York Medical College. Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to reestablish some degree of normalcy, we decided to resume the release of our episodes on the NCS podcast. As I say, the show must go on, and at least now you can listen to something that is non-COVID related for the next 20 minutes. Over the last 20 years, the inclusion of advanced practice providers in critical care departments has allowed them to emerge as invaluable, ever-present team members, crucial to the continuity of care and a stabilizing force for intensive care units. As such, the integration, advancement, and education of advanced practice providers is essential to maintain a high-functioning neuro-ICU. We're excited to collaborate with the NCS Advanced Practice Provider Leadership Section to launch the NCS Advanced Practice Provider podcast miniseries. Over the course of 5 episodes, we will discuss a variety of topics ranging from APP utilization and staffing models to billing practices, and hopefully present ways by which intensivists and forward-thinking advanced practice providers can work together to optimize the daily functioning of the neurocritical care units. I hope you enjoy this episode.
Hello and welcome to the Neurocritical Care Society podcast, APP mini-series. I am Angie Merkins, and I am a nurse practitioner currently practicing at Stanford Healthcare. I am also a member of the Neurocritical Care Society APP section. It is a pleasure for me to introduce Dr. Justin Kokusis, a nurse practitioner at the University of Alabama at Birmingham Hospital, to join us in this discussion of the ICU staffing models and the recent publication of supplementing intensivist staffing with the nurse practitioner's literature review. This is a thorough review discussing that when the APPs are part of the ICU staffing model, patient outcomes are positively impacted or show no difference from physician outcomes. The article also addresses the lack of literature on how to integrate APPs into the ICU team and gives great strategies to address this gap. So with that, I would like to welcome Dr. Justin Kokusis. Thank you for participating with us today.
My pleasure.
So I guess we're going to start off with some questions, and please feel free to add anything that you would like. The first question that we had was, if you don't mind, I would like to start off by asking if you could briefly discuss the emergence and integration of APPs into the intensivist role.
Well, I think, looking back at data when we did this paper, it seemed based on the data that the acute care role really showed tremendous growth around the mid-90s. And that's when utilization in acute areas was a lot more prevalent and started to go up, which was accelerated by the Balanced Budget Act of 97, which granted NPs direct reimbursement, allowing for the reimbursement of Medicare patients. So, once they allowed us to be reimbursed, obviously we began being used a lot more, and we were being integrated much more after that. Additionally, by the year 2000, NPs had legal ability to practice in all 50 states. And according to the American Journal of Critical Care, Viejo, over the past 5 years, an estimated 27 million Americans have gained health insurance coverage as a result of the Affordable Care Act. And I think that has also been a huge stimulus for us as APPs to be more utilized, because there's been a bigger push to utilize us to, we're cheaper as far as, cost effectiveness. More and more studies are showing, based on our paper, that our outcomes are similar. And as more and more data shows these things, that we have similar outcomes, that they can utilize us for a lot cheaper, and they can also utilize us in a time where there's a lack of physicians in critical care due to specialization. It becomes, something that just makes sense, more and more makes sense.
Those are all really great points. And yeah, that was very emphasized throughout your article. That was great to hear. Another question that was asked, how did the team explore a good fit APP to inpatient ratio for different units, given this is very difficult to standardize since some units are specialized versus more generalized?
Yeah, that's a really tough question. And I think a lot of it does have to do with institution, has to do with acuity, unfortunately has to do with financials. I think each institution really has to look at where they're at. And I think there's a number of ways that they can go about doing it. And some, some institutions may look at financials more than they should. They should, maybe look more at, safety and outcomes and stuff like that. But I think it depends on the institution. But ideally, I think that, based on data from American Association of Nurse Practitioners, American Academy of Physicians Assistants, and Society of Critical Care Medicine, the ratios ranged when they were looking for feedback from APPs. The range was anywhere from 1 to 3 to 1 to 8, with a median of 1 to 5. We're closer to 1 to 8 in our ICU where I work, but there's also a much more difference in acuity. We can have anywhere from very low acuity with lots of kind of overnight post-op observation to at times higher acuity if we have more strokes and if we have more subarachnoid hemorrhages and other higher acute types of patients. But I think as far as those ratios, looking at the total number of beds, looking at the acuity, if you're a MICU in the middle of a COVID pandemic, you're probably going to have ratios quite a bit different than if you're in a surgical or a neuro ICU with a lot of post-op observation types of patients. I think you have to look at your other ancillary staff as far as, do you have residents? Do you have fellows? The number of attendings, if you have a model which basically has a multidisciplinary approach with attendings, with residents, with fellows. I think in those multidisciplinary teams, it's a lot easier to have a higher ratio. We have a very robust multidisciplinary team. We round with attendings, residents, fellows, pharmacists, sometimes dietitians, respiratory therapists. We kind of round with the whole team. And I feel like that enables you to have a little bit of a higher ratio when it comes to at least APPs.
And at Stanford as well, we have the ratio 1 to 8 as well, as that we are capped at 8. And that's kind of been our standard. I want to get your thoughts on what should an administrator or a facility looking to supplement an intensivist coverage with APPs consider prior to starting that program?
Yeah, I think that's a good question too. I think there's several things that should probably be thought of. I think one is, why the hospital is wanting to change from their current practice model to a more, to bring on mid-level providers. Is it from a standpoint that they want consistency? Do they have residents that rotate month in and month out, and they want to have, a higher amount of safety and a higher amount of consistency by having APPs brought into the fold to, enhance safety measures, consistency measures? What are the state's laws as far as scope of practice and, what their thoughts are and what they think that their APPs will be doing? Are they wanting them, to basically practice as ICU physicians or along with ICU physicians, or do they want them more for, notes and billing and things of that nature? In Alabama, for instance, our scope of practice is much more narrow, is much smaller than it is in a lot of the northwestern states, some of the northern states. We have colleagues in Pennsylvania that insert EVDs from, if you were to ask a neurosurgeon whether they would think that mid-levels should be doing that, but they do it very effectively in other states. In northwestern states, APPs practice nearly independently in many situations. But in Alabama, our scope is much more narrow, but that is changing. And I think it's a good thing because we've shown that we can do a lot of these same tasks just as safe, if not safer, especially considering having, new residents coming in and doing a lot of these tasks. Just historically and observationally, I've seen a lot more, issues with procedural issues as far as unexpected outcomes or, issues with having procedures done with lower level residents than having mid-levels do it.
Thank you. What advice would you give to the APPs in an ICU setting where ratios don't currently exist for them And do you have any talking points for just starting a conversation with leadership requesting more positions or thinking about setting a ratio limit for providers?
I think as far as advice, I think that everything we looked at showed that a multidisciplinary approach was the best way to go. So I'm not advocating for APPs to take the reins and run ICUs by themselves, but I think, if we're all looking for best outcomes for patients, cost effectiveness, I think talking to leadership and looking at, how we can benefit patients from a safety standpoint, from a consistency standpoint, from as far as the hospital administration, they might look at more of a financial standpoint. We provide billing. Attendings can only see so many patients per day. They can't, overbill. They can't bill for 24 hours. They can't expect to be there for 24 hours. So there's a lot of benefits from a financial standpoint as well. But I think overall, from a patient safety, patient care, patient outcome, financial, I think there's a lot of benefits to bringing APPs into the ICU setting, not to mention the shortage of physicians to be able to care for all of the patients that we need to take care of.
Thank you. Those are really great points. The next question, your article talks about the overview of the 2 programs for onboarding APPs. Would you expand on the onboarding process for a successful APP transition into the ICU?
Yeah, and I think this varies greatly depending on where you go. It even varies greatly where I work. I think some of our other units onboard very differently, such as for MICU as they do for us. And I think that's probably the case no matter where you go. I think that when you're creating an onboarding program, you need to look at what your goals are. If your goals are longevity, attainment, I think that a lot of the studies show that a more robust onboarding program helps retainment and helps to ensure that there's a consistency across mid-level providers as far as being prepared, not feeling like they're being thrown to the wolves. And there was several different places that we looked at in our paper. I believe one was at Vanderbilt. They had an onboarding program that we looked at, which was basically like hospital orientation, classroom review, unit-specific orientation, and ongoing refreshers to ensure that there were not gaps in knowledge between providers. There were not gaps in abilities as far as procedural gaps. I think it takes, consistency. It takes oversight, something that should be constantly looked at. We looked at another model, I think that was in UMMC, but basically it was a Maryland Medical Center, and they had said about the importance of having a well-defined role for NPs to promote stakeholder support. They promoted a structured and comprehensive orientation program and focused on didactics, clinical, and simulation, and I think all those are good. Where we are, we have a simulation where mid-levels can go. They can go into simulation for central line placement, arterial line placement, and ensure that they have the steps and the knowledge base prior to, doing those procedures on patients. And I think all of those things are good methods. I think the key is ensuring that you have an onboarding program, that there's checks and balances to ensure that everybody's onboarded, that they have the knowledge base, that they have the skills, and that it's an open back and forth of information to ensure that if they feel like they need more training, they should be able to let somebody know that they need more training and not to keep that to themselves.
Those are all really good points and really supports the APP role. The simulation exercises are really important, which isn't incorporated in all programs, unfortunately. Last question, we were talking about APP as they were getting incorporated into the intensivist role. What are some ways to evaluate the performance and productivity, patient care outcomes, and promote career satisfaction and mitigate burnout?
Well, I think mitigating burnout is a very important topic in itself that we could probably talk about for a long time, and a topic in itself. But I think overall, ensuring that we focus on quality metrics, patient outcomes, evidence-based practice, quality improvement processes, in institutions that are that do research, involvement in research. I know there's some institutions that probably want to focus on billing and financials, and I think that's an important topic to look at to ensure that we are productive and that we support our presence. And I think making sure that billing is important for the fact that we reduce burnout by having the adequate number of mid-level providers and ratios, I think is important as well. But I think that just ongoing professional practice evaluation, looking at individual performance, looking at those quality metrics, looking at quality improvement, looking at outcomes, ensuring that billing is being done and is adequate, that we're not overbilling, that we're not underbilling, and that, those financials are optimized so that we can have an adequate number of APP to patient ratios to prevent burnout. I think all those things are very important.
Thank you. Well, that's all the questions that I have today. I just wanted to say thank you so much for joining us and giving us your insights on this topic, and we really appreciate your time today.
Yeah, my pleasure. Thanks for having me.
Thank you.
Did you know the Neurocritical Care Society now offers an intensive orientation course that covers a wide variety of foundational and disease-specific content specifically designed for advanced practice providers working in the field of neurocritical care? This widely popular course is comprised of 25 sections that contain review materials covering neurology foundations, critical care foundations and neurocritical care skills, pathophysiology and disease in neurocritical care, and recommended procedures in the neurocritical care environment, and is available in 4 different bundle options for those looking to gain their ENLS certification or gain additional continuing education credits. Visit www.neurocriticalcare.org to view the APP orientation course and other educational content brought to you by the Neurocritical Care Society. Use promo code PODCAST for an extra 10% off your purchase.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Sternnezer, and Chris Zamet. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.